Hi everyone, and welcome to our last video on the gross anatomy of the muscular system. In this video, we're going to kind of do the same thing we did in the last one, which is look at the muscles of the pelvis, lower limb, how they work together, and some clinical connections. Again, we're going to have another big one for OT, PT, but also kind of just anyone in general at the very end when we talk about the arches of the foot. So let's get started. So we're going to start here in the pelvic girdle. Now, the pelvis is where we transition from basically abdominal pelvic cavity into limb. And what do we have in the abdominal pelvic cavity? A lot of internal organs. And there's a big old hole, if you guys remember from our bone lab, there's a big old hole in the middle of the pelvis. And we do not want things falling through. So that is where the pelvic diaphragm comes into play. And that's what you guys can see here. Now, the pelvic diaphragm is made up of two muscles, though it could also be considered as like a muscle group. We have our coccygeus, which is going to be sort of this posterior muscle here, okay, connected to the coccyx. And then anterior to that, we have a group of muscles that we call the levator ani. We do not need to know their individual muscle groups. We just need to know the anterior pelvic floor is the levator ani, and then the coccygeus is in the back. As you can see from this diagram, this is for a female, we have a lot of stuff that's actually going to pierce the pelvic diaphragm. The anal canal, the urethra, and in the case of females, we also have the vagina. What does that mean? That actually means that these muscles are really important when it comes to the function of each of those areas. So you have your sphincter muscles, your external anal sphincter and your internal or external urethral sphincter, which are found located within the pelvic diaphragm. And then you also have, in the case of females, the vagina that pierces it and runs through. So that means that it can be injured, and if there are any deficits in the tone of the pelvic floor, you're going to have problems. So in terms of bowel and bladder control, because the external sphincters are located within that pelvic diaphragm, you can, if the tone is not there, have incontinence. And for females that give birth vaginally, that stretching as the fetus comes through the vaginal canal, we'll talk about that later, it can actually stretch the pelvic floor, and if you don't regain that tone back, now you can have things like as simple as urinary incontinence from, we call it stress incontinence because you're, laughing and then you pee a little. It can affect your core strength. You can have pelvic organ prolapse. So it's really important to keep this area strong. And kind of as we go through these other systems, we'll kind of come back to this pelvic floor later. So now we need to look at the muscles of the lower limb, and they are set up in a very similar manner to the upper limb. So what I mean by that is some muscles will only cross one joint, like your lateral quad, your vastus lateralis. It only crosses the knee joint, it only acts on the knee joint. Others, like your sartorius, are going to cross two joints. So it'll cross the hip joint and it will cross the knee joint. So that means it can act on the hip and it can act on the knee. And that again is important for the actions it provides. So again, some terminology overview. When we talk about the muscles that are connecting to the femur and causing the femur to move, we are not, yes, it causes the colloquially whole leg, which we call the lower limb, to move, but it's not acting on the leg. Muscles that connect to the femur act on the thigh. So from hip to knee, I can't show you, I'm not that flexible. From hip to knee, that's my thigh. In my hip, on my pelvis, if you were on my pelvis and connecting to my femur, you're a hip or a gluteal muscle. You're acting on the hip joint. Muscles that live in the thigh are typically acting on the knee joint. Some also act on the hip joint. And then the leg is considered from knee to ankle. So leg is knee to ankle, and those muscles are typically, again, acting on that ankle or the toes, kind of how the forearm muscles acted on the wrist and the fingers. So what we're going to do is take a look at all these different regions, talk about compartments, common things we see, and then connect it to real life. So let's start with our gluteal muscles. These are the muscles that are connected to the pelvis and to the femur. And what they do is, yes, they're going to move our femur and cause different actions like extension or abduction. But what their main job is to stabilize our pelvis. Okay? If our pelvis is wibbly wobbly, it's going to be difficult for us to maintain an upright position as well as to walk. So in the hip region, we have our gluteal muscles, the gluteus maximus, medius, and minimus. And then we have our deep hip rotators, which we'll get to in a minute. And then kind of on the side, kind of added to this, is our tensor fasciae lata, a TFL. Now these gluteal muscles and the TFL are really important for our ability to walk. Now, for those of you heading into physical therapy, one of the things that you're going to learn, and I learned this as a PT aid, whatever's below, yeah, the one below, is the gait cycle. Now, this is a diagram of the gait cycle, and as you can see, there's a lot of different phases to it. We're not going to learn all those. Basically, what the gait cycle is the cycle, the steps it takes for one limb to basically go from start to finish in the walking pattern. Okay? Now, it's made of two major stances, which then have individual components to it. The majority of the gait cycle is in what's called the stance phase. A good way to remember the stance phase is it's when your foot of the leg that we're looking at is in contact with the ground. So it starts when your heel hits the ground all the way until your toe starts to push off. So stance phase is the leg that's touching the ground. That's the one leg we're looking at when it's physically touching. So the gluteus maximus, your medius, and your tensor fasciae lata during the stance phase are all activated because what they're doing is stabilizing your pelvis so it doesn't tilt one way or the other, because if that happens, it's going to affect your ability to walk. Not only because your posture is going to be off, but now the other leg that's in the swing phase is going to have to do additional effort in order to do what it's supposed to do. So the swing phase, this is where we've now kicked off with our toe and the leg that we were just watching is in the air and it's being swung forward. So this is where we're using our thigh muscles primarily, like our quads and hamstrings, as well as the posterior leg muscles to kind of get that swing going forward. So stance phase is when the leg is on the ground. We're using our hip muscles a lot to stabilize the pelvis. And then we have the swing phase where we use more of our thigh muscles as the leg is in the air and swung forward. Okay? So this is where your gluteus medius comes into play. Again, your gluteus medius, you have your gluteus maximus, which is your big butt muscle. And you can see the gluteus medius usually kind of peeking out above it. So this is a muscle that's going to connect to we're going to simplify it for right now. It connects to the ilium, okay, and to the greater trochanter of the femur. So it's on that back side connecting to the greater trochanter, so it's going to act on your femur. Its action is to abduct the thigh, to bring it out, right? In reality, the practical application of what it does is it helps the other side of the pelvis get picked up. So when you plant your foot on the ground and you start to walk, that muscle is going to contract and it's going to help pull the pelvis on the other side up so it doesn't fall down. Okay, so when we're walking, we want our hips to be level, and if they sink, that is often indicative of a weak gluteus medius muscle. And I'll show you guys this in lecture because it's hard to do on a video. But there is a characteristic gait for a weak gluteus muscle called the Trendelenburg gait. So these are people that when they have a gluteus medius that's too weak, they have to like lean to the weak side, which is the foot that's on the ground, and like pull their leg forward because the gluteus medius can't pull the hip up, it's too weak. So we have to use accessory muscles and motion to help pull that leg forward, okay? So they kind of have this lean to them where they have to swing the leg forward like really emphatically. So that's an example of like a weak gluteus muscle. Something that most of you are going to be more familiar with is not so much a weak gluteus muscle, but a tired gluteus medius muscle. So if you go walking, go for a really long walk, maybe you're at Disneyland all day, maybe you've gone for a hike, and just like the upper portion of your butt, like right where it meets your back and kind of wrapping towards the side, that gets really sore. It's because you've been walking a lot and you're using your gluteus medius more than you normally do, and so it's going to be sore. So that's a better example for a lot of you guys. Now, if we take away our gluteus maximus, we take away our gluteus medius, now we can see a lot of these deeper muscles here. And they're called deep hip rotators because a lot of times what they're doing is rotating the femur, okay? We're going to learn most of these in lab, but the one that I want to bring to your attention today is this one here, your piriformis, okay? Kind of shaped like a pear. It's really fat on one end and kind of skinny on the other. You will notice that the piriformis has this big nerve that runs underneath it. That's your sciatic nerve. Now, sometimes the piriformis, for whatever reason, maybe an injury, overuse, again, when our bodies get injured, one of the first things that they do is swell. And if that piriformis swells because of injury, it will compress the sciatic nerve. And then you're going to get what's called piriformis syndrome, which is where you essentially get all the fun symptoms of sciatica. Pins and needles, pain going down the back of your leg. But in this case, it's not the nerve itself that's damaged. It's not coming from issues with impingement up in the lumbar spine. It's actually from a muscle just compressing the nerve. So that's what piriformis syndrome is. And you can stretch your piriformis, and it feels very good. And that kind of can help with releasing it and reducing that piriformis syndrome. Okay, onto the thigh. So again, just like with the upper limb, we have compartments. However, unlike the upper limb, we have a lot more of them because we have a lot more muscles down here. So we have, again, muscles between the pelvis and the knee. These are typically acting on either the hip or the knee, again, depending on their connection sites. We have a medial compartment, which is going to be right here. The medial compartment, these are muscles that are going to act on the femur, and they're going to perform adduction. So they're going to, in the jumping jack, they're what's bringing your legs back together. Okay, so these are your adductor longus, brevis, magnus, your pectineus, your gracilis muscles. These are your groin muscles, if that helps you kind of remember where they are. And speaking of groin muscles, groin injuries are very common athletic injuries. I pulled my groin. That is typically what's been damaged is the adductor longus, though the pectineus is also a common one as well. But the adductor longus is one of the main ones that's going to be pulled as it were. And usually what causes this is overstretching, overloading the muscle, like when you're kicking in soccer or when you're doing sudden movements, like when you're doing a juke or a quick change, you can pull your groin. So that's kind of the mechanism of action and the muscle group that's being damaged there. Now, if we go to the front of the thigh, this is where we have our quadriceps. It's a group of 4 muscles, the vastus lateralis, intermedius, and medialis, along with your rectus femoris. The main action of these muscles is to extend your knee, so to straighten your knee, but the rectus femoris and sartorius are also going to cross the hip joint. And since they're on the front of the body, they're going to flex the thigh. So they'll bring your knee up higher. Oh, as I hit my desk. So they'll help flex that thigh. Now, one fun fact about your vastus medialis, which is this guy right here, one of its main jobs is to actually keep an eye on your patella. It's going to pull the patella so it sits in the patellar groove. And if you have a weak vastus medialis, you'll notice you might have some knee pain because the patella will start to slide out of that patellar groove. So if you've seen knee braces that have the hole in the middle for the patella, that's actually to help your vastus medialis that might be weak. So while you're training it and getting it back up to strength, it can help take some of that load off and keep the patella in the groove. Now, if we move to the back, which you guys really can't see very well because my face is covering it, but this is your hamstrings. This is your posterior compartment. And the hamstrings are made of 3 muscles, the semitendinosus, which sits sort of on top on the lateral side, and then you have the semimembranosus, and then you have the biceps femoris. So the biceps femoris has 2 heads, a short head and a long head. But it's interesting because we have 3 muscles here, and all 3 need to be relaxed at the same time when we go to activate the quads. So that means when you're walking, when you're running. When that doesn't happen, we pull a hamstring, okay? And the one that's most often torn or damaged is going to be the semimembranosus. Now, what's also very interesting here is we have 3 different points of contact. We actually make like a little triangle with how these muscles are inserting into the surrounding knee area. So we have 1 attachment on the tibia, we have 1 attachment on the fibula, okay? If we only had those 2 attachments, it's very common to have one muscle stronger than the other. So if one muscle becomes stronger than the other, you're going to put torque on that knee joint because you're going to pull maybe on the fibula or maybe on the tibia too much, and it's create this twisting motion. So to combat that, we have a 3rd attachment that's going to go to the anterior surface of that knee joint. And so that is why you have 3 attachment sites, sort of 2 on the posterior/side and then 1 that comes around to the front, so that we can combat that torque, that twisting there. Okay, so that's why they're kind of set up that way. Now the other 2 thigh muscles I want to bring to your attention, they're thigh-ish hip muscles, and I'll explain why, are the tensor fasciae lata, which we talked about with our gait cycle. It's kind of on the side, but it connects to the IT band, which is also kind of connected to your hip muscles. And then we have our iliopsoas. So the iliopsoas we'll start with first because it's actually made of 2 muscles. In the lower back and the hip, we have 2 muscles that run together, the iliacus and psoas major, your tenderloin. So the psoas major and iliacus are going to come down, go through the pelvic region, and then exit and appear on the anterior thigh as a combined muscle that we call the iliopsoas, okay? This is the one that is the primary mover of your hip flexor. So when you talk about my hip flexors, this is the one. This is the big hip flexor, okay? Thigh flexor. And then we have our tensor fasciae lata. So let's orient ourselves here. We have our gluteus maximus and medius, and then we have our tensor fasciae lata. And you're going to see this band of connective tissue. This is called the IT band, the iliotibial band. And when you're walking, what it does is it pulls the ilium down and lets it's going to be assisting with the gluteus medius to kind of help with your pelvic tilts, more or less. Now, why do we talk about this? There is something called ITBS, iliotibial band syndrome, which is a very common thing to happen with runners. You can see that the IT band comes down here to the lateral side of the knee. Repetitive movements, like running, can actually cause a lot of friction in that area, and then that leads to inflammation and pain. So if people say, oh, I've got ITB syndrome, IT band syndrome, that's what they're talking about. It's just a repetitive strain injury. And if anybody has ever gone through physical therapy and had their IT band worked on, it is the worst pain ever. Absolutely worst pain ever. All right, now we're going to look at the muscles of the leg. And again, these are going to primarily act on the ankle though we do have some that are going to work on the knee as well. And just like the thigh muscles, we have 3 compartments. We have an anterior compartment, so that's going to be like where your shin is. So it's coming on the front of the foot. This is going to be where we have dorsiflexion. So again, here's my foot that's pulling the toes up towards the shin, dorsiflexion, and extension. This is where we get into some trouble as anatomists, because when we think about the upper limb, the anterior compartment was flexion. But now in the leg, in the lower limb, it's extension. So here's how we'll remember that, and we'll talk about it again in lab as well. If the palms of your hands are just like the soles of your feet, you have to rotate them this way to walk on them. Oh my gosh, where's my camera? So if I've turned my hand into a foot, here's my extensor compartment. This would be like where my shin is. And here's my flexor compartment. So now the flexor compartment of the leg is in the posterior aspect, and the extensor compartment's in the front. All you've done is rotate your hand so that you can walk on it. So the lateral compartment, notice we don't have a medial. The lateral compartment is where we have our fibularis muscles, and their job is to help with pointing the toe and eversion. So basically taking the pinky toe and moving it outward. So putting the sole of your foot outward, remember? And then again, the posterior compartment, we have pointing the toe and flexion of the toes, because we have our flexor compartment on the back now. Now, a lot of the muscles we have back here, we have a lot, they're also subdivided, superficial and deep. So the superficial muscles are the ones that we're more familiar with, your gastrocnemius, the big meaty component of your calf, and the soleus, which is like its sister muscle. You take those off and we see a lot of the deeper muscles, which are going to act more on the toes, and especially some of these are going to be important for maintaining your foot arches. The superficial group is going to connect together at the calcaneal tendon, the Achilles tendon, and connect to the calcaneus. So that's what we were looking at in our first video when we were talking about second class levers. We were looking at that superficial group as it connects to the insertion site of the calcaneus. So again, here's an idea for you. We have our anterior compartment here with our big tibialis anterior and our flexors. Then we have our posterior compartment. We've cut away our gastrocnemius, and now we can see the soleus, and then we take away the soleus, and we can see a lot of our flexor muscles. So out of these leg muscles that I just presented to you, there are 3 that I want to talk about. First is our fibularis group, so the ones that are in your lateral compartment. They are there to help ensure you don't have a lot of inversion. So again, inversion is where the sole of the foot goes into like medial, and then eversion is out. So they're going to help kind of pull the bottom of the foot so that you don't collapse inward. Okay. This muscle gets worked a lot if you're walking on uneven surfaces. So those of you that go hiking, maybe on uncharted territory that has a lot of rocks and it's very unstable, you might feel the side of your legs are kind of tired because they've been trying to make sure your feet aren't just going inward all the time. One of the deep muscles of the posterior compartment is your tibialis posterior, and it actually helps stabilize your foot arches. Okay, and we'll talk about that at the end of this lecture. Problems with this muscle are linked to flat feet. Now, flat feet you can just genetically inherit sometimes. Other times it's due to a weak tibialis posterior. One of the most important ones, simply because it does so much, is your soleus. So that's the muscle that's deep to the gastrocnemius, and it's going to do the same action. It's going to help with plantar flexion. It also is really important so that when you're standing upright, you don't lean forward on your ankles. So you don't, I can't do it, but basically so that your ankles, your shins don't come over and you lean forward. It's going to help pull back so that you keep that posture. This is the muscle, for those of you that work out, if you are on that machine where you sit down and you just do calf raises, okay, you're working the soleus. The gastroc isn't really active there, because the gastrocnemius is going to originate on the femoral condyles. and it's going to act on the knee. And because the knee is bent, the gastroc is inactive. So you're kind of isolating the soleus muscle when you're doing seated calf raises versus if you're doing standing calf raises, you're activating both of them, okay? One thing we're going to get into in the next couple of chapters as we get into our vasculature is we're going to talk about the idea of venous return, which is how our body gets the blood back to the heart. And spoiler alert, it's because of our muscles. As, for example, the soleus contracts, so as you're walking, it's going to squeeze the veins that are running in that area and push the blood back to the heart. That's why on long haul flights, they always want you to pump your calves so you can kind of push that blood back to the heart and not get a deep vein thrombosis. All right, the last things we want to talk about are related to the intrinsic muscles of the foot. So a lot of those muscles that we looked at in the leg are going to cross the ankle joint, either act on the ankle or act on the toes. Now that means they are extrinsic. They originate outside of the foot and insert into it. These ones are intrinsic because they originate and insert inside the foot. The foot is equally as complicated as the hand. There's actually 4 different layers to it. You can see a lot of different ones here. We tend to focus in lab on more of the superficial ones. So we have our extensor digitorum brevis on the top of the foot, our flexor digitorum brevis on the bottom of the foot, abductors and adductors, but not too much more than that. The main thing that these muscles do, they're going to help provide movement of the toes, but they also help with forming and stabilizing the arches of your foot. Now there are 3 arches in your feet. We have 2 longitudinal arches going basically from the calcaneus to the 1st and 5th metatarsal. So calcaneus to the distal 1st metatarsal is the medial longitudinal arch. And then calcaneus to the distal end of the 5th metatarsal is your lateral longitudinal arch. And then if we do cross sections across the distal end of the metatarsals and then as well as across the tarsals, those are called your transverse arches. So transverse is across the foot, longitudinal is the length of the foot. These are all formed from bones, ligaments, etc., and they help create that shape of the foot that allow us to walk properly and without pain. It absorbs shock, it gives us that cushion and elasticity to continue to walk. Now, the medial longitudinal arch is the highest one, and you guys know that. The inside of your foot doesn't touch the ground the same way that the outside of your foot does. So the medial longitudinal arch, because it's quite higher, it's more of the spring, has more of that elasticity to it, and it is strengthened by the tibialis posterior. So as we mentioned, I'll say it again, if the tibialis posterior is weak, not working for whatever reason, it's not going to give you that same high arch and it will start to collapse. And that's where you get flat feet. The lateral longitudinal arch, as you can see here, it's a lot less arched. It doesn't have this high point. It's a bit flatter. This is our stabilizer. So the medial arch is what gives us our spring. The lateral arch is what is keeping the foot in that sort of arched position. And then we have our transverse arch, which is kind of going across the foot. This is to keep your foot like this so it doesn't flatten out and splay like that. And you guys probably remember seeing some of the feet when we looked at our bones that were held together really great. They had these arches available. And then you saw the ones that were kind of held together with fishing line that just kind of were collapsed. And that is where the transverse arches come into play. So why do we care? Well, again, a lot of things you're going to see are issues with arches, high arches versus flat feet. And this is one reason I talk about this is not just a PT thing. Those of you that are heading into nursing, you're going to be on your feet all day. And so it's really important if you know you have a high arch or you have flat feet that you have the proper footwear. Otherwise, you're going to have loads of problems. Okay? So what high arches means is that the Medial longitudinal arch is super, super curved, okay? We don't have as much shock absorption. You put a lot more weight on the ball of the foot, and it causes a lot of pain because when you are walking, again, the stance phase starts when you hit the heel, and as we're kind of rocking, because of the arch of the foot, it's going to cause more pain. Typically, this can be treated with shoe inserts. That's kind of the main treatment here. And then we have the flat foot, which is where the longitudinal arches are actually lost. So we don't have that support anymore. We kind of just fall inward. This can lead to obviously pain as well. And then if you need to, you would put in an arch support to help kind of bring back the normal arch shape that you have of your foot. So that's it, guys. We did it. We are done with the muscular system. I will see you in our next video as we get started on the cardiovascular system. Bye.